variety of experiences. I've been in the military system, I've worked for the VA, and since 1995 in private practice in South Carolina. And I have always, for all of the thousands of patients that I've operated on personally, I've always been part of the anesthesia care team model for taking care of my patients. In the military, in the VA, and where we are currently practicing, we rely on CRNAs to provide anesthesia, and all of them have a supervising anesthesiologist. And just to illustrate how this team model works, since there's been a bit of confusion, I bring to you just a simple anecdotal story that happened about 3 weeks ago to me. I had a patient walk in for surgery who was on third patient on the schedule, had an IV established in a CRNA who was a 35-year veteran, excellent CRNA, administered her anesthesia through her IV, and a minute after this anesthesia had been given, our sedation, the patient stopped breathing, blood pressure went to dangerously low levels, patient turned blue, and the anesthesiologist was in the room, and in concert with the CRNA, they successfully resuscitated this patient over a 15-minute period, and but required reversing several of the drugs that had been given. It required using IV agents to boost the patient's blood pressure. The patient picked up, the patient was gagged for 10 to 15 minutes, and the team was ready to be intubating the patient, to ventilate the patient, and breathe for the patient, which didn't be necessary. The patient was finally stabilized with this team approach, and someone had said it's always necessary in these situations to have more than 2 hands and more than 2 sets of eyes. And so this team, this anesthesia care team model, which is what I've always practiced under or with, worked very well for this patient. The patient actually went through eye surgery and then actually walked out of the surgical center. It could have been a far different situation. So I certainly endorse the team model that's been talked about. And it must be difficult for you all to get a handle on this, but I'm happy to take questions again as a surgeon if you have any.
Any question? Representative Gillian?
I'll ask you, sir, what I talked about at the beginning. How will changing this law affect that care team?
Our center requires the anesthesia care team that I described to be in place. So in our particular setting, in any setting I've ever been in, I wouldn't be part of that setting if it weren't.
Changing that law wouldn't change that care team that you were involved in.
As they choose to do so. That's right. That's my understanding.
Yeah, so they could operate just as you are. Even with this law, with that supervision piece taken, they could still act just as you are right now, correct?
That's from what I understand.
Yes, sir. That's the way I understood it too. I just wanted to confirm, and if anybody has anything different, they're welcome to tell me. That's the way I understood it too. Thank you, sir.
Well, one of the things that I do want to say though is we certainly, I mean, from my perspective, I've relied my whole career and my whole surgical career. I've certainly relied on excellent CRNAs, and I think they're a great part of their care team. And I've never heard them have an issue with an anesthesiologist being at heart taking care of a really sick patient, which just happens to happen to all of us. All of our patients have lots of, this patient had a pacemaker, lots of comorbidities, lots of diseases come to us.
Any other questions? Thank you. Dr. Delaney?
Madam Chairman, thank you for the opportunity. I'm Gary Delaney. I practiced anesthesia in Orangeburg, South Carolina for 40 years. I'm a past president of the South Carolina Society of Anesthesiologists and also a past president of the South Carolina Medical Association. So I'm like the guy on the farmer's commercial. I've seen a lot of things. What I appreciate today is that we have doctors who have come up here, but they have not used the word physician. We need to understand there's a vast difference in the training that they receive and the training that anesthesiologists receive to take care of patients. In their heart of hearts, they know that they are not as well trained as the anesthesiologists that are in this state. They would ask you ask a question about who orders the anesthesia. They do not have prescriptive authority in this state. And so the order for the anesthesia either comes from me as the anesthesiologist or it comes from the surgeon. You ask about rural health care and how that would affect, and they talked about 3 physicians, 24 hours a day, 7 days a week. If the CRNAs covered that 24 hours a day, 7 days a week, are they is the past speaker so naive to think they're going to do that for free? Absolutely not. So don't delude yourself in the fact that they're offering something that doesn't fill a gap. They talked about supervisory language. Yes, there is supervisory language in a number of states, but there's also language that directs physicians to supervise nurse anesthetists. And they can talk about the 40 states, but it's just a matter, Representative Cox, as you said, a word semantics. However you slice it, it still comes out to be physician supervision. What I want you to think about right now, what's most important is a tenet that we have in medicine. And it's Latin. It's primum non nocere. Translated, that means first do no harm. I want you to write that down at the top of your notepad. And I want you to understand that we have presented evidence that it's safer when physician anesthesiologists are involved in the care of the patient. In my 40 years of practice, I stopped patients from coming to the operating room because they weren't ready for an anesthetic. In my 40 years of practice, I helped treat a number of patients that went south in the recovery room because the surgeon wasn't available. Because that recovery room was my baby. And that was a thing I took care of. So think about the World Health Organization and what that said. And their parent organization, the AANA, won't sign off on that because it's not part of their political agenda. So I want you to go home and I want you to look at your constituents in the eye and you say, we voted that this bill not come out of committee because we want to do what's safe for not only our families, but our constituents. Thank you for your time. Do you have any questions?
Any questions? Representative Cox.
Thank you, Doctor. So you mentioned CRNAs do not have prescription authority.
In this state, yes, sir.
In this state. So if we did pass this bill, what would we have to change to give them prescription authority? So, I mean, they don't want prescription authority?
Sir, I can't answer that.
Right.
Because I don't know.
Right. Okay.
I don't know.
Right. And so now it's up to the anesthesiologist or the supervising
That's
physician.
correct.
Okay. So I know we're prescribing the anesthesia, but what are some other things that you prescribe in your practice? Are there things in not having a medical background, I'm trying to figure out how to ask you this, when there are complications in post-recovery, are there things that an anesthesiologist prescribes?
For instance, we would, you know, in the perioperative setting, we might treat the diabetic to come in with a high blood sugar. That we can safely get that sugar down if it's in a reasonable range to go ahead and proceed with the operation. What happens in the recovery room? Do they need pain medicine? Do they need something to sustain their blood pressure? Do they need an airway intervention in the recovery room? Because they're not breathing correctly. They still have effects of some of the anesthetic on board. So yeah, there are a number of drugs that we administer. Are the nurse anesthetists trained to administer them too? Yes. I won't argue that point with you.
But they don't have the authority to do that.
The prescriptive authority
Yes, we
comes
do.
from me on the, as a member of the medical staff.
Okay.
There's our practice act. We need this.
Are you ready to go? Now, my question. Thank you.
It's 40-3-20.
Hey, Doctor, thank you for coming up and testifying. Let me tell you, sir, probably against your belief and listening to you, I think every member sitting at this table has the best interest of the people of this state.
I know you
don't
do.
take that lightly, sir. I
Yes,
don't
sir.
take that very lightly. And that's what I'm trying to do, what's best for the people. You say you have presented evidence this is the safest care, sir. I've got that evidence. And I've got evidence that is just the opposite of what you say. Books of it that says it is safe from way back when. So please don't think that I take this lightly, or anybody up here does, because we care about what we're doing. We're trying to make a good decision, not only for the doctors, not only for the CRNAs, but for our state and everybody else. And if we can't expand our care, I do live in a rural area that don't even have a hospital anymore. All we have is a medical center.
Right.
I used to go there, and I used to get put under by an anesthesiologist, CRNA, whatever it is. Can't do that anymore because I don't have that availability. I have to drive for quite a few miles to get to where I need to go. Not only have I had doctors, physicians, medical doctors, letters from them here, and talked to them that said, this bill is okay. They are very well trained, they handle things very well, and a lot of times they do it on their own, even though there's an anesthesiologist around, they do it. I haven't heard one side or the other nurses say, we don't need anesthesiologists, or we don't want their guidance. And I haven't heard many anesthesiologists say, I don't need CRNAs. They all work together in a team, and if they could come into the rural areas, that could be cheaper than sending an anesthesiologist, or they could work independently if they are safe, because that is our goal, I promise you that, sir. With the overwhelming evidence I got that they are, and that they're not. So that's us to make that decision, and that's the challenge that we have. But that's the best thing we're trying to do, and if they can, spread health care around our state that we are such in need of. You're living in a rural area, sir. I want to make sure if we can do that safely, I want to do that. I don't care which side it makes matter or the other. I want what's best for our citizens at an affordable cost. And I'm sorry if I hit one side or the other, but I'm telling you the way I feel, and I know this board up here is trying to make the best decision they can with the facts that they have. But because it's played both ways sometimes, we have to figure that out. Thank you. Thank you, Mr. Chairman.
Thank you. Are there any other questions? Was it Dr. Priest? Okay.
Madam Chairman, thank you. It's Pesci.
Pesci.
My name is Mike Pesci. I'm